Sure.
Representation.
Yeah,
CLAAS.
Dr. Ng, Dr. Yao, Dr. Bancha, if you could please turn on your videos. Thank you very much.
So, Jun?
Yeah, Dr. Ng, we're good to go. You can go on.
Yeah.
Go on ahead. Thank you.
Hello, everybody. Thank you for joining the CLAAS Connect Shoulder Instability webinar organized by COMEC. I'm Dr. Ng Wei Ming, currently working as an orthopedic consultant in Malaysia, special interest in shoulder and knee surgery. Today, we have three very interesting topics lined up for this webinar. After the webinar, there will be 10 minutes of question and answer session. So for the participant or whoever want to ask any question, you can start to type up your question in the chat message box there. So we will try to answer your questions by the end of after we present, three of us present the talk. So I would like to introduce the other panelists on the board, Dr. Yao Wei Pang, professor from Hong Kong University. He's going to he's going to share with us a talk of the arthroscopy bunk-up repair. And the Dr. Bancha, the last speaker, will talk about shoulder instability in elderly. So without any delay, I will proceed with my first talk first. Fracture dislocation with a large bony fragment from glenoid using arthroscopy ankle suture repair. Can you see my screen?
Yes, very well. Problem. Let's go.
So I'm talking about glenoid fracture in a fracture dislocation of shoulder. The prevalence of the glenoid fracture happen in first time dislocation is around 60%, 38% in recurrent dislocation, and they poses a higher rate of instability. We have a long-term impact of this fracture, which cause osteoarthritis of the glenohumeral joint. So classification of the fracture glenoid by Heidelberg, actually they include the fracture of the scapula also. What we interested today is just mainly fracture glenoid, intra-articular part of the glenoid, type 1A and 1B. So Gliani, 1999, share a very nice classification, which is used mainly for practical purpose. He divided the fracture glenoid in the shoulder dislocation in 3 types. Group 1 with the avulsion fracture, group 2 with the avulsion fracture and also the rupture of the capsule labium complex, where the bony avulsion heal more medially and inferiorly. Where group 3 that's divided to A and B depend on the glenoid bone loss, whether it's more than 25% or less than 25%. So to diagnose this fracture glenoid, X-ray sometimes is not adequate because if you're very lucky, you can see the broken glenoid piece. If you follow the line, the cortical line of the glenoid in the AP or AP view, but most of the time you'll miss it. So you need to look hard for this, especially after you do a CMR for the shoulder dislocation. MRI, yes, MRI is good to look for bony structure and also the ligament, any capsule, any cuff tear or any associated injury. If you want to study how much the bone loss is, I think CT scan is a better imaging to look for. So you can study using the end-on view of the CT scan. With you ask your radiographer to resect the humerus. You remove the humerus and look the direct end-on view on the glenoid. Then you can appreciate how much the bone loss is. So glenoid bone loss, we know that tends to have associated with the great instability of the shoulder. So the most famous, one important study by Bukat in 2000, they show that there's 2 types of bone loss. One is a reverse pear-shaped glenoid bone loss and the engaging HUSAC. So they study 194 patients, follow up for 27 months. They found that there's 21 cases with recurrent dislocation. That means a fail after Bankart repair. And they further analyzed among the 21 cases of fracture recurrent dislocation, 14 cases, 64% actually have a critical bone loss, either on the glenoid side or on the HUSAC. Whereas only 4% failure of the Bankart repair if there's no bone loss. This shows that with bone loss, there's a lot of instability despite you do a repair. So the other concept by Professor Itoy, glenoid tract, this interesting concept. They study the contact surface between the humerus head and the glenoid with the shoulder abducts from neutral to abduction and external rotation position. So they study the glenoid sit on the humerus head sit on the glenoid throughout this motion. So they come out the other concept of the on track and off track. This is very interesting. You can see that. So glenoid bone loss usually associated with mid-range instability, while the HUSAC lesion is an end-range instability. But look at this on track and this is on track. This is on track. You can see that the head is sitting on the glenoid throughout the range. Well, if there's a bone loss in the glenoid, so the tract is smaller, so the humerus head will dislocate. So you need to appreciate that how much bone loss will causes this instability. So Itoy go further to study the glenoid bone loss using they measure the glenoid bone loss using 2 methods. One is circular method, the other is using a vertical method. So he resect the glenoid using two methods. One is oblique, the other is vertical. So they resect about 9, 11, 19, or 25%, and they study throughout the arch of motion and which glenoid bone loss will cause us instability. So they come out with the idea. The figure is, if they resect the glenoid using an oblique cut, so if there's a glenoid bone loss about 21%, the shoulder is unstable if you do only a soft tissue bone cut repair. Well, if you resect the glenoid in a vertical line, so if there's a 25% of glenoid bone loss, so this causing a gross instability. So you need to think of a way how to augment the bone loss or how to repair the bone loss on top of the soft tissue repair. So indication to when should we do a repair for this glenoid bone loss, all right? So any fragment we understand is any bone loss more than 25%, we should consider do a repair. And any displacement more than 10 mm. So we look at the MRI or CT scan, we see that the humerus was decentral. That means it's not sitting on the center anymore. So this is an indication we go for the surgery. Previously, to do the glenoid rim fracture repair, usually we do an open repair. So Biliani group did the repair. Out of 200 patients, they do open repair. 25 patients still have a recurrent dislocation. So you can see that for type 1, 16 shoulder. For type 2, 5 shoulder. For type 3, 3 shoulder. Type 3A, 1 shoulder. So in this paper also, Biliani noted that X-ray only can noted 19 out of 25 patients of the shoulder dislocation have the glenoid rim fracture. Well, the advocate CT arthrogram is still the best to study the glenoid fracture dislocation and also to study any capsule division. For the open surgery done by Biliani group last time, previously, they found that they still have 3 patients with recurrent dislocation, 1 from the group 1, 2 from the group 2, and they have 1 case of superficial infection. This is a complication arising from the open surgery for the glenoid repair. So Marcus in 2004 published a paper in the KSSTA. Also, it's an open reconstruction of the anterior glenoid rim fracture. They study around 25 patients. All right, average of 43.4, follow up for 22 months. So with the glenoid rim fracture less than 25% bone loss, all right, 15 patients, they use a suture anchor to repair it. When the glenoid bone loss is more than 25%, they use a connected screw. So both groups have improved clinically. So all patients show radiological union. In the suture anchor group, 1 case has a local infection. Okay, 12 out of 15 cases with a reduction loss. That means the other is the reduction is step lower or higher, and 3 out of 15 cases have the arthritis changes. We are in the candidate school group. 1 out of 10 patients with the step off noted, but they have some metal problem because of the screw impingement. 3 cases and 1 metal loss, metal loosening, and they have 1 out of 10 cases of OA changes. This is previously when they do an open repair using the suture anchor and connector screw. Nowadays, we advocate using arthroscopy assisted repair because we think it's easier to do that, especially glenoid. The direction you put the screw is very low down. With the skin incision, either you make a very big skin incision, or the tendency of injure the surrounding structure around the deltopectoral approach is quite high. So arthroscopy reduction, this is the first time attempt by Dr. Cameron in 1998. They did for the first time dislocation, but this time they used for the case is a glenoid bone loss less than 25%. They use a connector screw with the arthroscopy assisted technique. So we also the other subsequent author advocate using the arthroscopy approach to this bony Bangkat. So they use a suture anchor. So Porcellini in 2002, they studied 250 cases with the shoulder stabilization surgery, shoulder surgery, 25 athletes with a glenoid rim fracture. Most of them is acute injury, less than 3 months after the injury. They follow up for 36 months. Most of the fragment is still less than 25% of the glenoid bone loss. So 23 out of 25 patients, the 23 out of 25 patients have a full shoulder function and return to same level of sport activity. Only 2 patients didn't really go back to the same level because they have some limitation in the external rotation. There's no recurrent dislocation in this group. Arthroscopy using a suture anchor repair. Whereas the Sugaya group first advocate using this suture anchor in 2005. They have just a small case series that time, 8 patients with 8 shoulder, 6 male, 2 female, age 31, surgery within 1 month, post-trauma, average bone loss is bigger, now it's 27.2%. They use a suture anchor, 2 to 3 suture anchor per patient. And this time they use a 3D recon view, all right, to study the pre and post-op. So they follow up for 27 months, all fracture heal up. This is very encouraging figure and clearly can see on the CT scan. Whereas the other techniques using arthroscopy, transglenoid pull-through technique by Dr. Hua in 2006. So they use a non-absorbable suture cell tied to the infraspiratus. Whereas Miller group in 2009 using the suture bridge method, 2-point fixation over the bone fragment. They think that using this method is more stable because you can prevent rotation and shearing of the bone fragment, and they have a stronger compression force. And Dr. Schubert in 2015 shared with us another paper. This time they looked into the retrospective arthroscopy assisted surgery, 23 cases. Okay, glenoid defect is bigger now, 27.5%, and they divide to 3 groups. 5 patients with a screw fixation, 5 cases with a mixed screw and anchor suture, and 30 cases just with anchor alone. So this is a method how they do it. They either use a suture anchor alone or mixture of suture anchor and screw. Then follow up about 33 months, all right? And clinical shoulder score all improve, range of motion improve. They only have 7 out of 23 cases have OA changes, mild OA changes, and all fragments heal out. But there's no correlation between the step up and the osteoarthritis. And again, they point out that there's no surgical complication using this arthroscopic glenoid repair. So the other paper by Sugaya group in JVJS 2015, they study around, this time they study 46 patients with a glenoid bone loss, more than 15%. So they managed to get 38 patient follow-up. So their repair method is quite interesting. So in this group, you can see that initially the bone fragment is attached lower down and more medially. So with excessive mobilization, they can bring the bone fragment, okay, more superiorly and laterally. And this group, they use at least 4 to 5 suture anchor to repair back the bone loss. By the end of the repair, you can see from the bone fragment in the lower inferior part, they manage to bring to superior and laterally. And they reported in this study, one patient with this dislocation 5 months after the surgery. This is through a very severe motor vehicle accident. Well, 2 patients had arthritic changes. Clinical score improved. The mean fragment size in this study is 4.7. All right, that means the bone fragment that they capture on the CT scan. And the mean bone loss after they study from before and after, they look at initially the bone loss, mean bone loss is 20.4. But after 5 to 8 years, they repeat the CT scan, they study the bone loss, in fact, is larger, negative 1.1. So this is a very good news for the arthroscopy suture ankle repair group, because they note that some cases, not even the bone loss is able to repair itself. In some cases, it causes a bone loss. The bone fragment will be hypertrophy and slightly bigger than before. So I illustrate one case of how I do it. I have this 31 years old man, right hand dominant, okay, fell down from the staircase on April, fell backward and direct impact on the left shoulder. He have anterior dislocation of the shoulder. After CMR noted there's a small, the glenoid rim fracture. There's no Hussack lesion noted. So this is a CT scan. You can see that this bone loss, I think, is less than 25%, but it's still considered huge. So MRI, you can clearly show that there's a bony fracture of the glenoid. There's no cuff injury or slap lesion. So arthroscopy view, first you go in, you need to clean out. No, not to worry. You need to clean out the blood clot. Use a shaver. So, and slowly use a probe or use a switching stick. Slowly mobilize the fracture. You should be able to mobilize the fracture back, reduce it in the normal space, in the normal place. So because this is a very fresh fracture. So this arthroscopy view, you can see that the bony fragment usually is still attached to the labrum and the capsule, so no issue, it won't be a loose piece. So I need to stress that in order to repair this bone fragment back, first of all, you try not to use a Y knot suture, because Y knot suture you need the intact cortex. So there's a broken cortex now. So if you put into the bone without the cortex, when you try to pull, then the Y knot will dislodge again. So it's better use a hard anchor. So I use this press FT anchor. So I use 3, one in the bottom, one in the top, and one circlage around the bone. You can't pierce the bone because you need a very strong device. I use the spectrum tool to just circlage around the bone, then tie it down. So this is an end repair. You can see that there's some cartilage loss, but the bone is you can fix back using the suture, and it's quite stable. So post-op regime, I usually put the patient on the shoulder sling for 6 weeks, pendular exercise for the first 2 weeks, gradually abduct the shoulder. So my aim is to achieve 90 degree of abduction and flexion in first 6 weeks, then neutral external rotation. Limit the external rotation is very important, and only achieve full adduction and flexion in 12 weeks. Only after 12 weeks, I will ask the patient to do more external rotation and in an abduction position. So patient may be able to go back to the spot in the 6 months. So currently this patient, this is a 6 week post-op. You can see the glenoid, all right, is initially is a drop off inferiorly, now is still there. It's back to the normal space. This is 10 weeks, so it's still holding well. So I still follow up this patient because it's only done on April. So in conclusion, arthroscopy assisted or fully arthroscopic surgery for fracture reduction and fixation of glenoid rim fracture is advantage, because we can have a better visualization of the fracture reduction. And important is left soft tissue dissection, minimal surgery trauma, and the recovery will be faster. And important is now we are very clear that the evidence show that we can restore back the glenoid to the normal morphology. That means in terms of correct back the bone loss. All right. Sometimes we have this glenoid hypertrophy as well. Thank you. Okay, so thank you for listening to my talk. Now I move on to introduce Dr. Peter Yao to present his talk on the arthroscopy bone cut repair.
Thank you, Dr. Ng. I'm Peter. I come from Hong Kong. A very good morning, good afternoon, or maybe even good evening to everybody attending this COMAC Congress. So I'm given an easy job today talking about arthroscopic bone cut repair. What I'm going to discuss with you will be some background information, what is my treatment protocol, how I do it, and some of the reflection of after doing this surgery for so many years and possible modification. So let's begin. For the management of anterior shoulder dislocation, we all understand there are two peaks in the presentation at the first time dislocation. One is the young age group at the 10, 20 to 30 years old. One is the not so young, 60 to 70 years old. For the young age group, it's mainly a soft tissue problem, a bone cut or plus or minus slab, which is mainly the labrum. Sometimes they can have significant bony issue, and the main problem is recurrent shoulder dislocation with some pain. But for the not so young patient, their soft tissue lesion usually is rotator cuff problem. There may be also biceps tendon rupture. So the more significant problem they present after the shoulder dislocation is pain, weakness, pseudoarthrosis, and sometimes even Popeye sign. But if there is significant bony problem, they will also present with recurrent dislocation. So for me, I would divide the case into first time and recurrent. For the first time dislocation, because from the literature, I know that young guys, they are active and they are prone to have recurrent dislocation, at least 80% or even more. I nearly always recommend surgery for those below 40 years old. But for recurrent shoulder dislocation, we know that they nearly all go into a repeated third, fourth, or even fifth time. I would recommend surgery for all the patients. The only exception probably is those habitual dislocator. And for the first time dislocation, the most important thing for me to differentiate is whether there's a fracture or no fracture. For a fracture, of course, they need to be fixed, no matter it's on the glenoid or greater tuberosity, which has been we are taught about by Dr. Ng already. For those no fracture, the most important thing for me is whether they are young or they are not so young. Sorry that the computer gets locked a little bit, is so a little bit delay. You can see the not so young who are mainly the rotator cuff problem. Benchai will probably tell you how to manage it. For me, for a young patient, then we'll do a bone cut repair. If it's a recurrent shoulder dislocation, once again, the dividing line is the glenoid bone loss. If it's a significant glenoid bone loss, then I will do something bone block procedure, both for the young and the older age group patient. But if it's less than 20% for the young patient, I will do a bone cut repair. So for the workup of the surgery for the young patient, the most important thing for me is an X-ray showing a dislocated shoulder, confirming the direction of dislocation and whether I suspect associated fracture. If possible, I like to do a CT with a 3D reconstruction, especially an end-on view of the glenoid, so that I can assess the exact bone loss. And MRI, I think it is good to have it, but not and must, especially if I don't suspect that there is concomitant rotator cuff pathology. And for the young patient, from this paper, we noted that the most important lesion for the anterior shoulder dislocation at the first time is IGHL lesion. The anterior band of inferior glenohumeral ligament complex, 100% is ruptured. 97% is at the label capsular attachment, the so-called bone cut lesion. 1% go to the Hegel, the humeral avulsion. The other 1% is the mixed substance. The other common pathology is the Hill-Sachs lesion. For the Hegel lesion, although it's good to use an MRI, but if intraoperatively, what you need to do is you put a 70-degree arthroscope and go to anterior S and look up, then you will be able to find it. As mentioned, the other lesion is the bony, 90% with the Hill-Sachs, and 22% go to the glenoid rim fracture. The glenoid rim fracture has already been covered by Dr. Ng, and I will not talk about it now. So It's logical that as a majority of the Bankart lesion is present, so the treatment is a Bankart repair. And for those with significant heel-start lesion, we may consider doing a Rempersar procedure. So the important question in an anterior shoulder dislocation, especially first time, is to do or not to do. So the classical wisdom of non-operative treatment mainly is because not all patients develop recurrent shoulder dislocation. However, we all understand that patients younger than 22 years old are likely to develop shoulder dislocation. So I must admit that I'm on the foresight, especially subsequent randomized studies showed that, of course, a repair after the dislocation will lead to much less dislocation or subluxation as compared with the non-operative group. But the advantage is not only to this, even for the non-dislocator, that means those without dislocation, a Bankart repair will lead to a less apprehension as compared with the non-operative group. This leads to a better functional goal, no matter is at the short-term follow-up or mid-term follow-up at 10 years for the repair group, and higher patient satisfaction, and also more likelihood to return to the pre-morbid contact spot. So as a result, as I told you before, I will prefer an operative intervention if it's a patient younger than 20 years old. So the surgery that I would like to do in the past is a Bankart repair plus Rempersar procedure. So the goal of the surgery of the Bankart repair is to repair the Bankart lesion back to the surface of the glenoid by arthroscopic means, and hence restoring the bumper effect of the anterior-inferior glenoid labrum. And also, we also want to retention the anterior capsulolabral complex by adequate capsulorrhaphy. So this is the cornerstone of the modern shoulder stabilization surgery. With this Bankart repair alone, the recurrence rate is shown to less than 10%. So you can do this in a lateral position, or you can do this in a big chair position. And for my friend Bencha, I know that he do it in a modified supine position. I personally prefer the lateral simply because it requires less manpower in the theater. And for the Bankart repair, I usually first put my arthroscope in the posterior portal and the initial viewing portal. With that, I open the anterior portal under direct vision and also open the anterior superior portal, usually through the myotendinous junction of the supraspinatus tendon. Afterwards, I will switch my arthroscope to the anterior superior portal. This will give a perfect view for the glenoid. Then we will want to repair. When we look at the glenoid from a top down, so the inferior aspect, that means the most lower part of the glenoid is the 6 o'clock position, and the most anterior is the 3 o'clock position. With Bankart repair, we want to put at least 3 anchors inside the bone of the glenoid. We typically put at the 5 o'clock, 4 o'clock, and 3 o'clock position. It's shown by literature that 3 anchor is important to retain the stability for the patient. And this is how I do a Bankart repair. First, I will prepare it. You can see that this is a typical recurrent shoulder dislocation with loss of the bone of the anterior inferior aspect of the glenoid, and the Bankart lesion has healed in the neck instead of the usual position. So the first thing is we need to do adequate release so that we can bring this part back. The release typically will extend at least to the 5.5 o'clock and maybe even to the 6 o'clock, depending how much the Bankart lesion is. And then usually for the superior part, I will go to the 3 or maybe even 2, depending how much higher is extend. And then I will wrap the bone so that I make sure the glenoid neck is vascular. Afterwards, I will use an arthroscopic ronger to remove the cartilage on the surface so that I can mark the 3, 4, 5 o'clock position that I want. So afterwards, I will try to take up the Bankart lesion to see whether it can go up to the desired position or not. Afterwards, the repair usually start at the 5 o'clock or 5.5 o'clock position. A useful trick is put the guard at that position and lift it up. Then you can see how easy you can see the whole anterior inferior aspect. The use of curved flexible suture anchor like the 1.8 is very user friendly. It helps you to go to the good trajectory without much difficulty. I like to use a small anchor, the 1.8, which is double loaded. But in this video, this is taken more than 10 years ago. I use a smaller anchor, which is only single load. But nowadays, I change it to double load. And then afterwards, I will put it up, and then I will take the suture to the posterior portal to facilitate further arrangement. So in the old day, after this step, I would like to pass the suture anchor or suture hook going through below the label lesion, and then relay one of the suture limb to the anterior part. And then the step is repeated for the second, the 4/0 cord anchor, and then to the 3/0 cord anchor, just like what you are seeing here. And after the anchor is inserted and also the label is passed through, then I will start the tying of the lock. The lock tying can be done either by a sliding lock or by a static lock, which will be up to your own preference. And with this surgical maneuver, usually we can obtain quite a good repair quality. I show you at the end of the wheel. This is the bumper effect. What we want is to achieve such a normal bumper height that restore the normal label height in the anterior aspect. So this shows you how I perform the Bangkok repair, which is very standard one for everybody. So with this maneuver, this is the workflow for what we do, which I have shown you. I think the most important point is, number one, we need to have the adequate release of the scar down Bangkok lesion so that there can be a tension-free repair of the capsulolabral complex. Second thing is we should repair it back to the surface, not the neck of the glenoid, so that it's more easy to prepare a good label height and restore the concavity of the glenoid complex. And the third thing is we need to insert adequate number of suture anchor, to me, which will be at least 3. Using a small all suture anchor, 1.8 millimeter, why not, will be a very good option. And finally, we should hope to recreate the bumper effect and proper retentioning of the inferior glenohumeral ligament complex. So the other thing that we need to tackle is the Hill-Sachs lesion. We all know that the Hill-Sachs is an impaction fracture over the posterolateral aspect of the proximal humerus due to the dislocated humerus engaged inside anterior part of the glenoid. It happens into 90%. It can be small, it can be big. With a longer the shoulder being dislocated and the higher number of the repeated number of dislocation, the bigger will be the Hill-Sachs lesion. So the problem of the Hill-Sachs is when the shoulder is externally rotated, the Hill-Sachs part will get engaged in the anteroinferior glenoid and causing a subluxation, lock subluxation. Even though the patient does not have a real dislocation, the patient will still complain. Of course, this is a balance between the size of the Hill-Sachs and also the size of the glenoid. This is why Professor Itoi has proposed the on-check, off-check concept about this, which is a very useful concept for us. For me, the most important thing is the glenoid. If it's more than 20% of anterior bone loss, I will think of doing something on the glenoid. But below that, I will just stick to the soft tissue procedure that I have told you before. So the goal of the remplissage procedure is to convert the Hill-Sachs lesion from an intra-articular structure to an extra-articular structure by tenodesis of the infraspinatus or capsulodesis of the posterior capsule, so that this Hill-Sachs will be covered up by the soft tissue and they can no longer go into the joints. And this is the way that I do it. Typically, I will first prepare the Bangkok first, but I will not tie it. Then I will go to the Hill-Sachs. I will first open an accessory posterior portal, which is, which is directly at the site of the Hill-Sachs lesion. this accessory posterior portal help me to locate the Hill-Sachs lesion, make the debridement of the Hill-Sachs and also insertion of anchor very easy. And then afterwards, I will put in an anchor, depending on the size. If it's a small size, I put in one. If it's a big size, I put in two anchor. I like to put it in the middle of the Hill-Sachs lesion, and I like to use an insertional anchor. But the bone of this part can be quite strong. So as a result, I don't like the screw-in anchor. You can see I use a 2.8 millimeter all suture wire lock anchor here. But if it is a big Hill-Sachs lesion like the one that you see here, I would like to use two suture anchor to do a double pulley configuration. And then afterwards is the suture placement. For the suture placement, first we need to retrieve the cannula back into the subacomial space, and then I will use a suture hook to pass through the desired position of the posterior capsule or the infraspinatus, just like what you see here. In the previous, after insertion of the anchor, already suture the relay, one to the anterior cannula, the other to the standard posterior cannula. Now it's very easy. I just capture it and get the two limb of the same suture from one of the anchor back. After finishing this job, I will use another suture hook to pierce through the corresponding position of the more superior part. And then once again, I will take another pair of suture. After the two suture is passed out, I will tie one of the limb from each suture anchor doing a double pulley. But I will not fully tie it because I will want to insert the other one. And then afterwards, I will pass through the capsule in the similar way, one for the inferior anchor, one for the superior anchor, and finally tie the one limb. Then I will leave this there and finish my Bankart repair. Afterwards, after everything Bankart repair is done, then I will return back to the ramp passage and I will tie the double pulley in the subacomial space, and then the job is finished. So this is the workflow of this ramp passage procedure. I would like to perform it before the Bankart repair. I will perform adequate preparation of the Hill-Sachs lesion because this is a biological procedure. I like to put one or two suture anchor on the Hill-Sachs lesion depending on the size. And I will pass the suture through the infraspinatus, sometimes also the posterior capsule. I will leave the suture untied and finish the Bankart repair before I return back. So on review of the result of this ramp passage procedure, actually is very encouraging in terms that the recurrent instability rate is only less than 6%. And 4% is a true recurrent dislocation, another 2% is a recurrent subluxation feeling. But despite of this good result in terms of the control of the recurrent dislocation, there is some downside about the ramp passage procedure, which is stiffness. Actually, after the ramp passage procedure, a majority of patients will experience some loss of external rotation, which is around 5 degrees in average. And in some extreme case, there can be quite a lot, which is uncommon. And there is significant loss in one of the two papers that is reported can be up to 30 to 40 degrees. But the main limitation of the ramp passage is the external rotation. It seems not too much affect the other, the forward flexion, the abduction, the internal rotation. But if this patient is need to do some high activity, sport activity like the pitcher, they may experience some problem, simply because some of these patients will experience posterior shoulder pain during forceful motion of the external rotation, and this may make them difficult in returning to the activity. So, as I mentioned, the role of the surgery of the Bankart and the ramp passage is to decrease the recurrent dislocation rate. For the Bankart repair, as I mentioned before, the goal is to restore the bumper effect and to retention and to capsule complex. Actually, there are two parts of this surgery. One part is the label repair, to repair the bumper height. The other part is to retention the IGHL, which is mainly by capsulography. I don't know whether you have this feeling. I have a feeling that when I perform this surgery, majority is very good. But sometimes when I put too much attention on the label repair, creating a very good label height, I will miss the part on the retention. The capsulography may not be good. On the other hand, if I put too much attention on the capsulography, then the label height, especially over the anterior-inferior aspect, is not as good as I want. I always is finding how to balance this seesaw in good enough. And on top of this, for the patient with a big heel sacs, they need to do a ramp massage procedure. I also find loss of the external rotation is a worry for me. So as a result, I think whether I can improve this. And in the recent few years, I try to change a little bit my procedure by separating the label repair and the capsular plication into two parts. First, the double low suture anchor, because we have two sutures for the same anchor. Actually, I can designate one suture for the repair, the other suture for the capsulography. I will show you the workflow here. So this is a small Bankart lesion. To be honest, no matter what you do, it will be good looking. But anyway, I just use this as a demonstration because this is one of the earliest things that I do. Similar to before, we'll prepare the 3, 4, 5 O-cord position. In the 5 O-cord, we'll insert a double loaded anchor, the suture put to the posterior limb. And the suture pass here, I just focus on the labrum and capture a good label tissue. And then 3 out of the 4 limbs of the suture will be taken through the label pass to the anterior portal. Afterwards, you can see the capsule is quite lax here. Then I will put a tension suture on the capsule, usually a number 2 high strength suture. And then I will take both the limb of the tension suture to the anterior portal, as you can see here. Using the 2 limbs of the suture anchor by a modified SMC lock, I will do a capsulography. By doing this, I will be able to tighten the capsule without dampening the Bankart lesion itself. If I'm not happy, I can actually put 2 tension sutures here. And then afterwards, I will complete the job of the label repair by taking both sutures to the posterior part. You can see with this capsulography, the tension of the inferior anterior band of IGHL is already been restored. And as you see afterwards, I will take the suture and tie my Bankart repair. If after this first suture, I'm still not very happy, I will also do a similar thing for the 4 O-cord anchor. But if I'm happy enough, then I will leave it like this. My impression after a few years cases is that usually after the 5 O-cord capsulography, even without doing any further Bankart repair, I can already centralize the humeral head. So this is the things that I'm now doing for my Bankart repair. I'm quite happy in the sense that there is minimal recurrent dislocation rate and the external rotation loss is not as much, especially in the condition that I need to perform a ramp massage procedure. And after trying this procedure for 1 year, to be honest, I don't do any more ramp massage procedure for my patient anymore. Of course, if the glenoid bone loss is huge, I need to sort out for a bone block procedure in the glenoid reconstruction. But if just a glenoid bone loss less than 20%, I will just do this capsular repair together with the capsular plication together with the label repair. So this ends the presentation for me today. This is a summary slide for the first time dislocation. As I mentioned, fracture, always fix the fracture. If it's no fracture, but if a not so young patient, usually conservative, except if there is pseudoparalysis, then we need to do a surgery. If it is a young patient, I need always advise them to do operation. And the type of operation that I advise them to do nowadays is a Bankart repair plus capsular plication without ramp massage procedure. This ends my presentation today. Thanks a lot for your attention. So without any delay, I would like to unshare my slide and also introduce the next speaker. The next speaker is my good friend, Dr. Ben Chai. Dr. Ben Chai is an associate professor at the Department of Orthopedics, Faculty of Medicine, Thammasat University of Thailand. He's a very experienced shoulder surgeon, and his talk is very lovely. You will enjoy it just like me. So Ben Chai will talk about shoulder instability in the elderly in the subsequent 25 minutes. Ben Chai, I hand the time to you.
Thank you. Good afternoon. I'm Dr. Bansha Chun Chuchit from Thammasat University, Thailand. thanks the organizing committee, CLAAS Connect, for the invitations. And nice to see old friends, Dr. Ng from Malaysia and Professor Peter from Hong Kong. And also thanks for my 6 fellow from this preparation of the talk. So for the shoulder dislocation in elderly, why is this important to talk about the shoulder instability in elderly? The answer is because the shoulders in the young and the elderly are not the same. In elderly, the mechanism, pathology, and line of management are totally different from the young. So dislocation in elderly may be associated with cuff tear, large bone defect because of the osteoporotic bone. TT fracture is more common in elderly. Nerve injury also common in elderly, which are totally different from the young. The incidence of dislocation is bimodal distribution. It's common in the young, skip the middle age, and common again in elderly. Now, our lifespan gets longer. We as a surgeon will see more cases of shoulder instability in elderly. So it is important to be clear how to manage this patient. The recurrent rate and pathology of the dislocation is different. 25% in elderly and 90% in the young of the redislocation rate. The cuff tear is more common in elderly. The incidence is about 60%. In contrast, the capsule label tear is common in the young, 70 to 100%, but cuff tear is only 15 to 20%. So these are the difference. This is a terrible triad, which is more common in older patients, composed of shoulder dislocation, rotator cuff tear, and nerve injury. Okay, this is not common in the young also. The prognosis of this triad is depending on the nerve recovery, and most of the time it's recover. And the second is the how good you can manage the rotator cuff. Don't miss it. The shoulder instability composed of static and dynamic stabilizer. In the young, the static stabilizer, capsule label complex is more important than the cuff. So this we call the entry mechanism. But in older patients, the dynamic stabilizer play a bigger role. So this is a posterior mechanism, is a head depressor. In the rotator cuff muscle strength, if the rotator cuff muscle strength reducing by half, it will be increase the displacement by 50%. This show how important the dynamic stabilizers are to keep the glenohumeral ligament or glenohumeral joint stable. About the mechanism of injury. So in elderly, it's always low energy trauma, which is different from the young, which you have a high energy trauma like sports injury or traffic accident. So this less common in the elderly. Most of the time, it is very low energy trauma. So it can be entry dislocation, posterior dislocation, or infra dislocation. So the technique of reduction is also different from the young for the elderly, because I do not recommend you to do the leverage technique in elderly because of the soft bone. Sometimes the patient have the heel sac lesion, big heel sac lesion, you may create a fracture. So this is a modified traction, counter traction for the antero-inferior dislocation. It's safe, easy, and reproducible. It was published in 2014. So this is my patients. I do the traction, counter traction, modify, because she has a very big heel sac, and this patient had 3 weeks of dislocation. Try not to do the leverage technique. You can create a fracture or fracture dislocation. I saw this fracture dislocation more than 5 patients. So very careful when you try to reduce this dislocation in elderly. So this is the way you should not do in elderly. Try not to do the leverage technique in elderly because sometimes you create a fracture or fracture dislocation because of osteoporotic bone, or sometimes the patient have non-displaced neck fracture, like this example. See that? This patient have the GT fracture, but after the reduction, it is a fracture dislocation. Okay, so we need to do the reverse shoulder arthroplasty instead of conservative treatment. So post-reduction X-ray is important. You need to look for the tuberosity fracture. You need to look for the size of chronic rotator cuff tear, because some patients have impending cuff tear or pre-existing cuff tear. So you need to look for the acromion spur. Okay, need to look for the suture size, looking for the humeral head migrations. So if you see these X-ray findings, thinking about the patient may have pre-existing cuff disease or impending cuff tear. So don't forget to look at the tuberosity, right? This patient have the displaced tuberosity fracture. So CT scan, when we do the CT scan, when should we do that? If there's no glenoid fracture or suspect the head split fracture, to calculate the amount of bone loss, or in some patients that have persistent dislocation, we want to see the degree of bone defects. So the CT scan will be useful. So MRI, we do that in MRI when the patient had persistent pain and weakness after the dislocation, because simple labral tear, the shoulder pain should be better within 3 weeks. Or especially the patient who had first-time dislocation at the age more than 40 years, you should consider the MRI in these kind of patients. So non-operative management, yeah, is important. We do conservative treatment in the patient who had first-time dislocation, no displaced GT fracture after the dislocation, no traumatic cuff tear, and good shoulder stability. So this is an example of one patient has a fracture dislocation of GT. So after the reduction, I put her in the abduction brace, okay, and conserve. So I think it's important to put the patient in abduction, external rotation, and exercise the deltoid. Otherwise, the fracture will be displaced posterosuperior superior. So that's why we need to put the patient in abduction, external rotation. And this is the result. I saw many young surgeons do a lot of GT surgery because they treat it conservatively in the wrong way. Okay, so you do it the right way, the patient will have good result like this. Okay, this is 4 months after the conservative treatment. So weakness after the reduction, why you should think about because of cuff tear or not. The patient would have painful pseudoparalysis, or because of the nerve injury, axillary nerve or brachial plexus injury, that may have painless pseudoparalysis. Like the first patient have the massive cuff tear, the second patient have the axillary nerve palsy, and the third patient is a brachial plexus injury. So this is the incidence of nerve injury in shoulder dislocation. Axillary nerve is most common, 86%, suprascapular nerve 30%, and musculocutaneous nerve about 24%. So this nerve complication is about 5 to 55% in all dislocation. Even low energy trauma can create the brachial plexus injury in elderly. 13 to 80% require surgery if there's no sign of recovery within 3 to 6 months. The most common tear pattern is a posterosuperior superior tear. The patient would have the weakness of supraspinatus, infraspinatus, and sometimes the teres minor. So this is an anterior tear. The patient may have belly up side, Napoleon side, lift up test positive, internal rotation lag side positive, or back hug test positive. That is worse prognosis in this kind of patients, but it's less common than posterosuperior superior cuff tear. So like this patient, we need to evaluate the pseudoparalysis and find the root cause of it. It is because of nerve problem or is it because of tendon problem? This is a bad sign. If you have fixed proximal migration, soft tissue procedures may not able to solve this problem. This may end up with the reverse shoulder arthroplasty. Muscle atrophy is a bad sign of disuse atrophy, or is maybe from the nerve injury. So the patient may get longer recovery if the patient have the muscle atrophy. So this is the treatment algorithm. You should looking for the pathology. Is it just the capsulolabral tear, or is it the capsulolabral tear together with the cuff tear? Is it repairable cuff or repairable labrum or not? Is there any arthritic change or bone loss? Is there any severe lock dislocation? So in this situation, you may end up with Latarjet or may end up with the shoulder arthroplasty. So this is my preferred position. We call this TU supine position. It's very simple. And you look in these pictures, the patient just used the local nerve block, right? He can go back home right away because no intubation. Very comfortable position. Just let the patient sleep and local nerve block. So this is my articles about this TU supine position for this shoulder arthroscopy. It's very convenient. Okay. So I use 3 portal for the surgery. I start with my posterolateral portal. It's about posterolateral. It's not the lutein posterior portal. So this portal you can see better, and also you can work better, right? You can put the anchors at 6 o'clock, and also you can do the posterolateral repair at the same time. So I put my anterosuperior portal just underneath the bicep, just above the bicep in front of the AC joint. My anteroinferior portal just above the subscapularis between the MGHL and SGHL, okay? And these 2 portals should be not too close. The angle between these 2 portals should be about 70 degrees. You should not too close, otherwise you get portal jam. And we start the capsulolabral repair using the Y knot. We start at 6 o'clock position after complete the label detachment. And after that, if the patient have cuff tear, so we can continue to do the cuff repair using the same position. You don't need to change, okay? So this is like one example. So the rotator cuff tear indications for cuff repair in this dislocation with cuff tear is a traumatic cuff tear. So most of the patient need to be repaired because this is traumatic cuff tear. You have no role of conservative treatment in traumatic cuff tear, okay? And also persistent loss of function. So I show you the Y knot. I prefer the triple load Y knot. We call this the 3-in-1 techniques. 3-in-1 hole. It's very fast, very easy. Okay, so you can put suture hook the spectrum, and you pass 3 sutures into 1 hole. So you have less problem about the tissue strangulation, less tissue trauma, and this is faster. Okay, so after that you tie the knot, but you just tie 1 knot in the front, 1 knot in the back, 1 knot in the middle. Okay, and then that's it. And then you can do the double row, the second row repair. Okay, so that's very simple, straightforward, right? For this the cuff repair, the 3-in-1 holes technique. Okay, that is a medial row. And after that, you retrieve the sutures to the lateral row, and then we use a pop lock for the lateral row repair, right? I prefer to put my lateral row very far away, one close to the bicipital groove because of the good bone quality, and also another one close to the posterior cortex. Okay, so you can have the very wide area of suture distribution. Okay, that's it. Okay, so that's after the repair. Yeah, that is the 3-in-1 holes. Yeah, it takes you for the repair only half an hour. Okay, but we spend a lot of time for the tissue mobilization, for the bursectomy, but for the repair it takes very short time. Okay, and you have less soft tissue strangulation using this technique. Okay, I use Y knot at the middle row and pop lock at the lateral row. So you need to think about what is your main problem. Okay, if the patient has small size cuff tear, the main problem is the labrum, it's not the cuff. Okay, But if you have the medium-sized cup tear, your main problem is both, is together the cuff and also the labrum. But, sorry. Yeah, this one. So if the patient have medium-sized cup tear, thinking about both problem, the labrum and also the cuff, okay, you need to fix both. For the massive cuff tear, so your main problem is mainly the cuff, okay, it's not the labrum. Most of the time, sometimes you didn't see any cuff, any labral tear in the massive rotator cuff tear with dislocation. So this is a very simple clue, okay, small size, thinking about the labrum, medium size, think about both. If you have large size cuff tear, the rotator cuff is the main problem. So this lady, she's 70 years old. First time dislocation, she showed me, she just stand up from the toilet and the shoulder dislocation, just positive apprehension sign, okay, at 45 and 90 degree. So I'm very surprised. She's 70, but she have good rotator cuff, you see. Supraspinatus, subscap is good, but she has heel sac lesion, engaged heel sac lesion, but there's no bone, there's no glenoid bone loss, okay? So this is very weird for me. So this patient, I performed the arthroscopic examination. We see that the patient have the big heel sac. So we put the Y knot into the heel sac. I put 2 Y knot into the heel sac. I think Y knot is very good for osteoporotic bone because you can put it into the subchondral bone also. It's very small. Don't need to make a pilot hole. So after I pass my suture into the infraspinatus, posterior capsule, then I address my anterior label, put the Y knot there, okay, and then repair. So we're starting repair from posterior portal to eliminate the axillary pouch, and I always use the double load anchors. Okay, for me, I think the Y knot is pretty good for the osteoporotic bone. I never have problem with my Y knot. Okay, so after that you do the limb massage. Okay, so we discuss with Peter again. Why don't you love limb massage? I love limb massage so much. Okay, Peter, you need to answer me why you don't love limb massage. So this is a 50 years old male. He has first time dislocation from minor traffic accident. So he has so much pain and cannot move. The nerve is good, right? But he cannot move. He came to see me about 6 weeks after the injury. The patient gets stiff shoulder. He had the tuberosity fracture, you see, GT. But luckily, 6 weeks, the GT already healed. And you look at the glenoid, you see that the patient have broken glenoid. At this right picture, you see that the glenoid pieces is so big. So his problem is the glenoid defect. So I discussed with him that I will fix his glenoid. Yeah, so we get in when detach everything, the glenoid defect is about 30%. It's so big. So we use the spectrum to repair the posterior labrum first. Okay, and then using the soft anchors. Okay, you see that we can repair this bone. I prefer to do this way using the soft anchor. Yeah, and then you can reduce this big piece of bone. You see that it's very big. But don't worry, I don't like double row because it's too complicated. I use this single row, make a big bite. Don't worry that it will overhang because the head will mold this fragment to flat. I never have the problem with this overhanging because after you release the traction, the head will mold this fragment nicely. Okay, so this is after the repair, and the patient getting much better, and the healing is perfect after 3 months. Yeah, he also have the labral tear in the back, so we also repair his posterior labral lesions also. Okay, this is the bony band cut patients. This patient, she had dislocation, but she has the medium-sized cup tear. So when you see the medium-sized cup tear, thinking about labral tear also, right? Like I show you in the algorithm. So she has a 4-time dislocation. From the MRI, we can see that the patient have a medium-sized cup tear. There's a heel sac lesion also. When we get in, we found that the patient have labral tear, right? So in this situation, you need to address both the labral pathology and cup pathology. Okay, so I always repair from the back, repair the labrum. So after I finish my labrum, I go to the subcutaneous space, okay, and then we do the labral repair. Sorry, the cuff repair. So also use the 3-in-1 hose technique. Yeah, it's very simple, easy, and very fast. So the patient doing well after the surgery. So this is the post-op about the 4 months after surgery. The patient doing well and had the full range of motion. She's very happy. So this is a medium-sized cup tear. So in other patients, this is also common in elderly, the GT fracture, right? This patient have 2 months history of GT fracture. So after the conservative treatment is failed because the fracture displaced more and persistent instability. So this is the inter-op findings. Yeah, when we get in, we found that the patient have good labrum. For this patient, the labrum is intact. Okay, so we do the release. Okay, put the Y knot at medial row. Okay, and after that, we tie the medial row and doing the tuberosity fixations. Okay, for the small size tuberosity, it's good to use the arthroscopic treatment. For the big size, I do open, but for the smaller size, I prefer to do this arthroscopic fixation. So you see the GT heal nicely 1 year after the surgery, and the patient had pretty good results after the surgery. So the next patient, he's the very active marathon runner. So he has accident. So he's an athlete. So he has accident during the games. He during the game, there's some traffic accident. So this patient have posted dislocation, right? And also there's a fracture of the scapula and also distal clavicle, very complicated. So I get in, I fix the bone first. I fix the AC joint and fix the scapula of the patients. And then we get in to do the arthroscopic posterior capsule labral repair. Okay. So this is the labral repair. The patient have torn labrum and also extending to the biceps. So that is after the labral repair. Yeah, here's some bony fracture also, right? After the fixations, this is the about 1 year post-op. The patient have pretty good motions. So I removed the hook plate already. It's healed nicely, and the patient motion is pretty good. So now he can go back to the games again, right? And here's some nerve injury also at the beginning, but the nerve come back after the surgery. He also have the suprascapular nerve trauma because the fracture extend very close to the nerve, and maybe it's because of me. When I put the plate in, I do some traction to the nerve. Okay, but anyway, all the nerve come back. Another man, he's nearly 60 years old, neglected dislocation from traffic accident. So we have a lot of traffic accident in Thailand, you see. Even he's the 60 years old, so he ride a motorcycle and there's some traffic accident. It was missed because this is a posterior dislocation. So I discussed with the patient that I will try to do arthroscopic release first. Okay. We get in the joint and try to release the rotator interval and slowly external rotate. And finally, we can reduce the head back. Then we do the McLaughlin procedure, put the suture anchor at the defect and repair the subscap back. So after repair the subscap back, the head was reduced to the center and performing the posterior labral repair, right? So this is a films after the surgery and the patient getting much better. This is a few weeks after the surgery. Now the patient not come back to see me. So in Thailand, if the patient not come back to see you, that means he's good. Yeah, because if he's not good, he will come back to see you, right? Yes. Another patient, he's 58 years old. He's a doctor, dermatologist. So it was missed again, the posterior dislocation. Oh, it's long time, so the cartilage was gone. Yeah. So I discussed with him, I need to do joint replacement for him. Another 52 years old, I just do that last month. Actually, I sent this into the group. Peter, you saw that?
Yes.
These patients, right? 52
Very
years old, lock dislocation after the seizure, okay? So now the seizure can be controlled. So the defect is so big, you see from the MRI, right? From the CT scan, it's so big, but the glenoid defect is not too bad. So when I get in, I found that the patient have very big Hill-Sachs lesion, but there's no capsule. So this patient, we need to decide to do the Latarjet procedure because he has no capsule. And also we need to fill the defect with the allograft, okay, and do the Latarjet. And then we do the fixation of the lesser tuberosity back. I prefer to do lesser tuberosity osteotomy to get the biceps tenodesis. So the shoulder getting stable, okay? And the patient now is getting better after the surgery. And this is the films after surgery. Yeah, it looked nice. So another patient, 76 years old. We have a lot of elderly dislocation and different scenarios. This one, minor fall and misdiagnosed 3 months. Oh, no, 4 months after the fall. So the patient came to see me. I say she's 67, 76. So reverse should be the solution for her, okay? Because she have torn everything, rotator cuff, okay? But this patient also have nerve injury at the beginning. I discussed with the patient that I will try this because even you have nerve injury, the nerve always come back, right? So luckily the nerve come back, right? He's happy after surgery and have good motions and function after the surgery. But this patient, 73 years old, same neglected dislocation, same scenario. Yeah, but this is about 6 months after the injury. So I discussed with him that I will try to do the same way. Okay, you have the fracture dislocation, but you also have nerve injury. So after the surgery, the patient doing well, but he come back to see me with this. You see that the muscle atrophic change and the nerve is not coming back. So this patient had the dislocation again because of the bad nerve. So I revised that again, put a bigger spacer, and he come back again and again. And finally, this patient got the heterotopic ossification. Yeah, so now he's not come back to see me because he's good, but he cannot live up, but the shoulder is stable now. You can see that there's some heterotopic ossifications. So now the shoulder, but the nerve finally is not coming back. So take home message for this elderly dislocation. Shoulder dislocation in elderly is not the same like in the young. The soft tissue dynamic stabilizer are more important, and the rotator cuff is commonly torn and must be repaired. Even in the emergency department, the reduction must be done carefully to avoid the fracture during the reduction. Often combined label, capsular, and cuff repair is need to have a good motion and function. If it cannot be repaired, that is the option of the replacement. Thank you. So now I think it's the time for the Q&A. Prof. and Peter,
Yes.
is there any
I don't see
questions
any
from
on the screen.
participants?
I don't see any.
Yeah.
Probably they're sleeping.
So I saw some questions that sent to me personally. So about the LEM research, Peter, some audience they asking about the LEM research. Do you think LEM research plays some roles to provide the stability of the shoulder joint, Peter?
Yes, definitely yes. This is why I'm doing ramp massage in the past 10 years until 2 to 3 years ago. Because if there's a large heel sac, but the greener defect is not that significant, you need to adjust both the Bangkok lesion and also the heel sac lesion. At that
Yes.
time, the way for me to address is to do a Bangkok repair and also a ramp massage procedure. I'm happy about the reduction in the dislocation rates, just like that is shown in the literature. It's quite very acceptable. But what I don't like is in some of the patients, they do have a loss of external rotation. And in a very minor group, they also have some pain. But at that time, that means 4 to 5 years ago, I don't have any good method. But not until 3 to 4 years ago, I tried to separate the labral repair and the capsulorrhaphy with the surgery that I showed you in my last part of the presentation. After doing half to 1 year, I found that actually the dislocation rate is very satisfactory. And then I extended to those with a significant heel substitution, but of course, no significant glenoid problem. And I also found that actually the result is quite good in terms of recurrent dislocation rate, but they don't have the problem of the external rotation loss or posterior shoulder pain. This is why now I'm not doing hand massage anymore. But you can challenge it in a way that, well, you don't have enough follow-up. Maybe a few years later, the dislocation rate come back. It may be the case. But I'm just saying at the present moment, I think it's still quite satisfactory for my result. So as a result, I will prefer to stick with this maneuver.
How about you, Prof. Ng? Do you love LEM research or not? Do you have any problem about the external rotation loss in your experience?
Yes, I noticed that a few patients of the repressors, there's some limitation of external rotation. But I think it's a beautiful procedure because you don't need just additional around 30 minutes. You can fill up the heel sac with the infraspinatus muscle and tendon. So the only is external rotation, but it's not very. I don't have experience of very severe limited external rotation up to 20 degree. Just a mild external rotation. But usually after a while, the patient, if you don't tell them, they won't realize that there's a limitation. That's an experience.
So I also have no problem about the external rotation loss. Some surgeons don't believe in LEM research, like your boss, Professor Younger Lee. You remember? So he, at that time, I think he showed us one patient that the ligament dislocation many times. He did to do the revision for this patient, and finally, the last operation he did the LEM research for this patient, so he can solve the problem. So I think it's true, but I believe Professor Younger Lee, he's very honest. Yeah, so that's why I believe in LEM research. Yeah. So Peter, your mention is also, your comment is also important. I will look in my patient any problem, because I think sometimes if you repair the muscles into the defect, you may create some problem, right? You should repair the tendon into the defect, right? Should not go to medial.
Tendon or the posterior capsule. Definitely not the muscle.
Yeah, not the muscles. Yes. Very good. So that's some Q&A for Professor Ng. Which portal you can do double row fixation, the fragment? Professor Ng.
So I use a standard anterior portal and add additional anterior superior portal. So to hold the fragment, then after that I will put the suture and tie it. For the second question, reduction of bony fragment usually is not an issue because you do it fairly early. Usually you need to do it before 3 months, most of literature, but usually I do it within 1 month or 2 weeks. So temporary fixation, if a big fragment, you can use a K-wire to drive through, but usually you holding with your grasper of the labrum and capsule complex, not direct on the bone piece. You can pull it like how you do a tensioning of the IGHL in the soft tissue bone cut. Then using the suture, you can slowly reduce it and fix it on the place. Of course, may not be 100% edge to edge the fixation of the fracture, but you can bring it back to the defect and fill it up with the bone and also the capsule labrum complex. That's adequate.
So, thank you,
Yeah.
For Professor Yao, Peter. There's a
Yes.
question for you. How can you balance both sides, bone loss at the glenoid and the humerus to do limb massage or not? How
Actually,
can you balance?
I don't really understand the question. I suspect he is asking how to assess the bone loss in order to decide whether to do a ramp massage or not. If it is
Yes.
the case, the first thing I will do is, if it's a recurrent shoulder dislocation, say 5 times 10 years, I will routinely perform a CT with 3D reconstruction showing the end-on view of the glenoid, because the first thing affect my decision is the glenoid size. If it is
Right.
less than 20%, I will not do the glenoid surgery. If it's more than 20%, I will do the glenoid surgery. In those doing the glenoid surgery, say either letter J or eating hibernate procedure, that means adequate bone graft, I will not need to do a ramp massage, simply because the bone process is so good, it take care of any other things. But if the glenoid bone loss is less than 20%, I will decide to do a soft tissue procedure. 3 years ago, as I mentioned, I will do both ramp massage and band cut repair if the heel size is large. Then the question comes, what is large? This is a tricky question. I don't use a CT to assess. I just do an arthroscopic assessment, and I feel, oh, this one seems worrying to me, and then I will do a ramp massage. But to be honest, there is no good quantification here. But nowadays, as I mentioned, if it's less than 20%, I will simply do a capsular plication together with my band cut repair and skip the ramp massage.
Okay, there's one question for me. He asking me about the osteoporotic problem. Okay, so in this situation, how to manage this osteoporotic problem, how to choose the anchor. So I will tell you the why not is pretty good, because in osteoporotic bone, you don't need to make a pilot hole, no tapping, right? And you can change the direction in case you want to put the why not at the humeral head. Try to go into the subchondral bone, not perpendicular. If you go perpendicular, it will be soft bone. So you can put it deeper into the subchondral bone, right? So I have no problem at the humeral side for me for the cup repair. And for the glenoid also, you can tap it deeper, okay, for this why not. So for me, if the patient have osteoporotic bone, I will use why not and put it in the subchondral bone, change the direction, not going perpendicular, but we go into tangential into the subchondral bone, okay? So for my second question, he asking me about how to do the limb massage to avoid the limitation exhaustion. So as I discussed with Peter, so the way we do limb massage is we doing putting the tendon into the defect, not the muscles. So do not make a very big bite into the muscles. So put in the in the tendon, not into the muscle. That would you can limit the exhaustion. So that's one question for every speaker about, may I ask the panelists if the bony band cut is big? Do you have any tips on passing your suture medial to the bony band cut fragment? So what's your trick to pass the suture? You pass through the bone or not?
Okay, let's say is a bony fragment is very huge, very big.
Yes.
You can't even pass through. What you can do, you can put the anchor, you can put a suture on superior and inferior to the bone block, to the bone, then you tie it. So if you have a device like the big bone piercer, from some company, you can
Mhm.
actually pierce through the bone. That means the needle is very strong enough to pierce through the bone. But most of the times you need to struggle. Probably you're not able to catch the largest diameter of the bone fragment. Probably slightly inferior or superior to that.
Yeah.
To pass your suture through.
How about you, Peter?
For me, I will do the things a little bit different. I will not only use suture anchor to do the fix the big bony backup. Instead, I will use button, just like the arthroscopic letter J said, proposed by scale below. And usually with a big bony banker, the labrum is still intact. I will put suture anchor in the superior and the inferior to that bony banker. Induce the suture anchor to reduce the bony banker first. After bony banker is reduced, then I can drill the transosseous tunnel and put the button on the two sides. But without tightening the button, you can still do some manipulation to make that the bony fragment in a perfect position. Then you tighten the button. Then you give a.
Oh, you mean the button in the joint, right, Peter?
The button in the anterior aspect of the glenoid neck and the posterior part of the glenoid, which is a transosseous. You need to go from back to front.
You drill to the bone, right?
Yes.
Okay.
Because you are drilling using a drill, then there's no problem in getting through the hard bone. Yes, I use a very strong suture passer, but even for that, I'm still worried. So I found that this method will be easier for me.
Okay. So for me, I think the portal is very important for when you're dealing with a big piece of bone. You need to use the 5 o'clock portals, okay? Because the direction is like that. You need to pierce through, right? Not like this. If you go like this, you cannot go around. Like you use the 45 degree or you use the 90 degree, you cannot pass through because the big piece of bone. You need to go through it like this, go straight. So your portal, I think, is very important. You put the lower portal, like 5, 7 o'clock portal, pierce it through, and then you pass it not through the bone, but at the junction between bone and the labrum, okay? And very good detach this piece of bone and try to throw the suture. It's not easy to retrieve the suture at the tip of the instrument. You need to throw the suture because it's difficult to find that. So use the spectrum, the straight one, or if you have the something that have metal inside, that should be fine. Okay, and then you can take the that nitinol, from these 5 o'clock portals. And I agree with Peter. We need to go above and below the piece of bone because the bone is always like this, right? This is the bone is like this. So in the top and the bottom, the piece of bone is small, but in the middle it's big. So try to catch the above and lower first, okay, to reduce it. I agree with Peter about this point. Okay, there's another questions about the in limb research, better doing not tying after the bank cut repair or before?
I do it after the bank cut repair.
How about you, Peter?
Also, after the bank cut repair.
Okay, second question. In athletes with shoulder instability, with shoulder instability, which indication for surgery during the season or wait out season? In season or wait for out season?
I will advise to wait out season because obviously after surgery, we want to protect and let the repair tissue to heal. It takes time, not so fast. So in this case, wait out for season will be better.
How about you, Pavan?
Yeah, I agree because I only allow the athlete back to the sport probably around 6 months after the repair. So definitely it's not during the season.
Okay. Any more questions?
Bacha,
Yes.
you don't have any issue. I have some problem, especially if there's no cortex. I found it's very difficult to put the Y knot, to anchor the Y knot. So that's why I prefer to use a fresh FT now for this or fresh fracture, not the soft tissue bunk cut.
Why? Why?
Yeah. Because
You don't
I
trust
found
why
that-
not?
Why not? When you anchor, it's okay. After a while, because there's no cortex on the you basically you go through a raw bone area, cancellous bone.
Yes.
So if there's no cortex, very difficult. You will dislodge the suture again.
Actually,
my-
you can put to the opposite cortex, no problem. You can tap it deeper
Mhm.
to the opposite side, and when you catch the bone, you can go deeper and then you pull. It will be stable.
Oh, that means you go to the other cortex.
That's right.
Oh, good idea.
Is any contraindications? No, right? Very easy, simple. You go to the opposite cortex. It's very stable. Okay.
Okay.
Yeah. So that's why I love why not. Okay. The name is soft anchor, but it's not soft. It's very strong. Okay.
All right.
Good. So
Any other
Peter, any?
So
More
Benka,
question?
I noticed there is a question for you in the
Yes.
Q&A. Maybe I read
Yes.
it for you. It say in
Yes.
the elderly patient shoulder dislocation with large GT fracture, in which
Yes.
case
Yes.
would you do open surgery?
When it's large GT fracture, the problem is that you cannot use a suture anchor to fix that because your anchor, the lateral load should be very low, right? You should put it at the diaphysis of the bone. So that's not safe. Okay, I think for the large bone, it's better to do open surgery.
So
Yeah.
maybe I add a follow-up question to this. So how big is big?
How
Can you
big is
give
big?
a size? So that
So
the audience-
whenever there is the triangular shape, you see triangular shape of the bone that extending to the proximal humerus, okay, about 1.5 centimeters. I think more than that, I cannot put the anchor. It's too big. Yeah. So I
Agree.
prefer to use the open surgery, deltoid split.
So your
That's-
open surgery, Bancha, you use a screw fixation or you use a plate?
No, stop using screw fixation. I saw a lot of complication. You make a mini open, right? And then you pass the heavy sutures at the bone tendon junction, and then you do it like parachute. Put it tie in to the small plate or put it on the screw. I prefer to use the small plate, okay? And you put this suture onto the plate. It's like tension band, like that. Yeah.
So I found
That's my way.
sometimes it's quite tricky because the fracture, although it's from a GT, but it's more posterior. Sometimes it's
Yes.
hiding under the acromion. Not
Yes.
easy to do that. So what approach you use for this GT fracture?
A deltoid split. I recommend deltoid split because if you coming from deltopectoral, it's too far. You cannot manage the posterior part. So deltoid split is easier. And it's just direct. You open the deltoid split, you can see the fracture right away.
So you split between the anterior and the superior deltoid interval.
Right. I draw the line from the distal clavicle to the acromion in the same line. Then I make a vertical incision, not transverse like in the book. I think vertical, very simple, parallel to the deltoid fiber. About 2 to 5, 3 centimeter is enough. You can see very well.
So Bencha, let me have a follow-up question with Dr. Ng question. So suppose you have a chronic GT fracture, which is just like you say, posterior, high under the acromion. You use a split delta approach. What's the trick for you to release it and get it to the front?
So in case we have a lot of neglected GT avulsion. So first I will do arthroscopic release because from open surgery you cannot release very well. So for
Agreed.
arthroscopic release, you can release very nice, right? You can release the collacohumeral ligament. You can release the fragment very nice, okay? And after that, you judge again. You need to, can you do it arthroscopically or can you do it open? But most of the neglected GT is always small, in my experience. It's never big. because that big piece cannot go upward, cannot go that far. Okay, it's always small. So in the neglected GT fracture, it's always small piece. So I think nearly 90% of my cases, I do arthroscopic surgery for this neglected GT, this fracture. Sometimes it spreads very far.
Bencha, is there any occasion that you found after the release, this neglected malunited GT still cannot be get back to the anatomical position? What will you do?
I have one patient that I cannot reduce it back because of the chronic. That patient also have done some plate fixation, a lot of scar tissues. So finally, we need to do reverse for him.
Yeah,
in that patient. Yeah.
Agree. Okay, Bencha, I also see some more question in the Q&A.
Yeah.
Maybe I read out for all of us.
Yes.
The question is, if an elderly patient, example, age 60, had their first episode of dislocation at a much younger age, example, 20 years ago, that means in between there is 40 years. Is there any difference in the management compared to when the first dislocation just happened at the age of 60? That means the first scenario is a repeated dislocation, but the first time is at 40 years ago. Then now 60 old, that is okay. The second scenario is the first dislocation is at the 60 years old. Do you have any difference in the management?
Yes. Me first.
Yes, Bencha, is your first.
So most of the dislocation, you need to ask when is the first dislocation. So we have many patients that dislocation when he was 20, okay, and he has recurrent dislocation, and sometimes the dislocation stop for many years, and he come back again at 60 and recurrent dislocation. So this patient, we have no cuff tear. In my experience, no cuff tear at all. If they had dislocation first time in the young, okay. So this patient, I will do arthroscopic, label repair, intraarticular is mainly. But first time dislocation in elderly, in 60 years, so you have higher chance of cuff tear, up to 60% from the incidence. So that's my experience.
But Bencha, may I have a follow-up question on this? Will there be any rule for long operative treatment in these two scenarios? That means you don't do surgery, just rehabilitation.
Just rehabilitation. Yeah, we need to discuss with the patient that he can modify his activity and he can stop this dislocation by rehabilitation, exercise, and modify his activity. So I think surgery or not, it depends on the patient.
Okay?
Agree. Yeah, I don't decide for the patient. It's just by themselves.
Dr.
So I agree partly with Bancha. The thing is, if you have a first dislocation younger age and subsequent dislocation at the older age around 40, 60 years old, probably just a straightforward dislocation with some labrum injury. But if the traumatic injury first episode in the older people, so there will be associated injury like a cuff tear. So my experience is this sort of patient with the first time dislocation elderly with the cuff tear and the labrum tear. So if there's no bony truncat or heel sac, probably this sort of case, I just go ahead and do some cuff repair. I think after the cuff repair, the shoulder will be stiff enough and dislocation usually is not an issue. That's my personal experience. I'm not sure how's Panchashri after you do the instability and also the cuff repair.
Yeah.
Is there stiffness, any severe stiffness in this organ patient?
No. It tends to dislocate again. It's not stiff. So it depends if the patient have the medium-sized tear. I always repair both because they always have label tear together with the cuff tear. But for the massive tear, rarely I didn't see the label pathology. So just the cuff surgery is enough for this massive tear. You agree?
Yeah, I agree with that. If
Yeah.
you have a massive cuff tear, usually the labrum usually is not a big issue. Usually I don't bother to repair. I just do a cuff repair.
Right.
For me, I would do the things a little bit differently.
Yes.
Actually, I would treat both groups as the same. For a patient coming to me, 60 years old, first time dislocation, I always treat him conservatively, especially he does not have any other symptom. Because I noted that from the literature, the recurrent dislocation rate is well below 15%. But
Yeah.
in case he has persistent pain, then rehabilitation first. Failed the rehabilitation, I will do an MRI. If the MRI does show that there is a full thickness tear, then I will discuss with him about surgery.
Yeah.
But the purpose of the surgery is mainly for the treatment of the rotator cuff rather than for
Pain
dislocation.
relief.
Yeah, so this is my usual approach.
Do you inject the steroid in this traumatic cuff tear in case the patient comes to see you with pain and stiffness?
To be honest, I don't do this. I don't do this.
You don't do that.
I don't
How
do
about
this.
you,
So
No, with the traumatic injury, I won't put the steroid inside. I won't put steroid. Yeah.
You're afraid of infection, or when you repair the cuff, it will not heal? What is your concern?
Yeah, both. I think steroid probably can help to reduce inflammation and pain, but not good for healing. So I won't do that. I won't do that.
Yeah. But there's some literatures mentioned about the steroid injection in the cuff tear. You have no problem with the healing. So for me, if the patient have the small size tear, no recurrent dislocation, I will try one shot of steroid injection. If the patient feel better, pain relief, okay, I will do conservative. But most of these cases, they will have the big size tear if they have recurrent dislocation, because small size tear rarely recurrent. Any more questions, Peter and Profeng?
I cannot see further from the
Yeah.
Q&A box.
Okay. So I think, so now it's about the time to finish the webinar today. So thank you, Professor Ng and Professor Peter Yao from Hong Kong and Malaysia. And thank you again, everyone, for joining today, the CLAAS Connect webinar. Shoulder Instability webinar Connect has many more webinars in the store in 2021. So please wait for upcoming events, okay, everyone, and stay safe and healthy. Okay,
I see you.
bye-bye.
See
See
you.
you, Peter, and
Yo.
Bye.
bye, everyone.
Bye.
Bye.